You know, before the mid-20th century, if you broke your jaw, well, it was pretty grim. Imagine weeks, maybe months, with your mouth just wired shut.
Yeah, that's maxillomandibular fixation,
Mm.
basically tying the upper and lower teeth together to keep the jaw still.
That was the standard for mandible fractures.
But things have changed, right? Now we see orthopedics getting people moving fast after breaks, and that's influenced jaw fractures too. The goal now is a quick return to function.
It's a huge shift, and it really highlights how much we've learned. So this deep dive is all about the biophysics of these fractures, based on some really interesting research.
Okay.
And what you see straight away is just how complicated it is to compare treatments.
Absolutely. I mean, just think about it. You've got all kinds of different breaks, different ways to assess them, so many treatment options, loads of different
And
devices.
even different ideas about what success actually looks like, right?
Exactly. Okay,
Right.
so what's the main goal for us in this deep dive? What are we trying to get at? Well, we want to dig deeper than just, make it stiff, make it strong.
Hmm.
We're aiming to understand the actual science behind how these fractures work and how treatments affect them.
Okay.
Hopefully, this discussion will clear up some misconceptions, maybe build a more logical biomechanical picture.
Sounds great. So where did the source material take us? What ground does it cover?
Right. So we'll start with how a normal healthy jaw works, how it handles sources. Then we'll contrast that with a fractured jaw.
Makes sense.
We'll look specifically at common spots like the back of the jaw, the posterior body and angle, and also symphyseal fractures right up front in the chin.
And the treatments.
Yeah. And finally, how using single plates versus multiple plates changes the whole biomechanical situation.
Okay, let's jump in. First off, healthy jaw versus fractured jaw. What's the core difference in how they behave?
Well, a healthy mandible, it's dynamic. Depending on where you bite, which muscles you're using, you get these zones of tension pulling apart and compression pushing together.
And these zones aren't fixed.
They shift around based on the forces. Now, when it's fractured, you basically got separate pieces. Treatment is about stabilizing those pieces in the right place so they heal, and you can get back to normal function eventually.
And how do we get that stability? Is it all about plates and screws?
Not entirely. I mean, you need very little movement at the break for bone to heal. Sometimes the body forms a callus, like a natural internal splint, which helps.
Right.
But often, yeah, we rely on devices, plates, screws, sometimes external frames, to limit that motion during healing. The main goal is always to create an environment where you can function as normally as possible while it's healing.
Got it. So these fixation devices, the plates and screws, they're pretty crucial. How do they actually transfer force across that break?
Think of a plate like a bridge across the fracture gap.
Mm.
When you chew or apply any force, that plate helps carry the load from one bone piece to the other. And doing that generates stresses, both tension, pulling, and compression, pushing around the fracture. It's actually kind of amazing how even simple devices can have pretty big effects on the whole jaw system.
Yeah, I can see that. Going back to older treatments, you mentioned wires, arch bars. How did they handle force transfer?
Well, wire loops were pretty basic, mostly just holding pieces close together. Arch bars, which you still see sometimes, are better at stopping the pieces from moving when loaded.
How so?
If the bone pieces try to pull apart, the arch bar goes into tension, and thin metal is pretty good at handling that stretch. But under compression, they tend to buckle or bend pretty easily.
Ah, okay. So better against pulling than squeezing. What about the bone itself with an arch bar?
If the bone ends are actually touching, they can still help share the load when things are compressed. Bone's pretty strong under compression.
Right.
But then, of course, if you add wiring, the jaw shut, maxillomandibular fixation, you basically stop almost all movement and eliminate normal function for that time.
Right. So then came plates and screws, changing the game. How do they alter how stresses are managed?
Okay, so plates get attached with screws. As you tighten those screws, you actually push the plate down onto the bone surface, creating compressive force between them.
Okay.
And friction is key initially. The plate won't slide against the bone unless the force overcomes that friction. If it does overcome friction, then the load gets transferred by the plate pushing against the sides of the screws.
So more screws mean more friction, more stability.
Generally, yes. More screws increase that friction and the overall stability.
And you hear about different kinds of plates, standard, locking plates. What's the difference there?
Good question. Standard plates really rely on that tight plate-to-bone contact and friction. Locking plates, though, they have threads in the plate holes that the screw heads lock into.
Ah, okay.
So their stability depends more on the screw-to-bone connection and the screw-to-plate lock. It's a bit like external fixation in that sense. The plate doesn't need to be pressed super tightly against the bone.
Does that change how they're put in?
Yeah, placing locking plates often means disrupting more of the surrounding soft tissue. But the core principle holds for all systems. That screw-to-bone connection is absolutely vital. If that fails locally, the whole repair can just fall apart.
The weakest link, yeah.
So let's dig into that screw-bone interface. Why is it so critical?
Well, that connection point has to handle the forces without damaging the bone around it. If you get too much stress concentrated right there, the bone can get damaged.
And even tiny movements matter.
Exactly. Even micromotion, really small movements at the screw site, can build up and lead to instability. Ideally, you want a system of materials designed that behaves a lot like the bone itself, because forces always take the stiffest path.
So, wait, are you saying a repair could be too stiff? That sounds wrong somehow.
Yeah, it does, but yeah. If the whole plate screw system is way stiffer than the bone, it can actually concentrate stress on the bone right next to the inner screws, the ones closest to the fracture.
And that's bad. That can actually damage the bone, make the screws loosen, and boom, the fixation fails. It's interesting, even when a fracture heals perfectly without loosening, that plate screw system still carries a lot of the load across the heel site.
So it changes how the bone is stressed long term.
It does. It alters the original stress pattern, but it still lets the jaw function.
So the main aim isn't just maximum stiffness.
That's a really key takeaway. The goal is more about using materials and techniques that kind of simulate the original structure. You need enough stability to stop big movements while it heals, sure, but you also have to think about function and how the repair itself affects healing. Too stiff might actually hinder proper bone healing.
Okay, this ties into force equilibrium. You mentioned that earlier. How does that fit with applying plates?
Right, so no matter how many plates you use or what kind, all the forces acting on the jaw during function have to balance out. It's always in equilibrium.
A balancing act.
Exactly. A whole circuit of forces gets set up, and the stress flows along the stiffest parts, the areas most resistant to bending. And because any single spot on the jaw feels multiple stress types, pushing, pulling, but also sliding or shear forces, and twisting or rotation, any plate needs to handle all of that wherever you bite.
So it's way more complex than just tension here, compression there.
Yeah.
Which brings us to stress shielding. What's that and why should we care?
Okay, stress shielding happens when the fixation device, the plate, is much stiffer than the bone it's attached to.
Right, forces take the stiffest path.
Precisely. So the plate ends up carrying most of the load, effectively shielding the bone at the fracture site from the mechanical stress it actually needs to mature and remodel properly.
So the debate isn't if it happens, but if it matters clinically.
Exactly. Does it significantly affect the healing outcome? That's the question.
And what determines if it is significant? How does the bone heal well with a plate there?
Well, the source suggests a couple of possibilities. Maybe bite forces are naturally lower right after surgery and then gradually ramp up as things heal, giving the bone increasing stimulus.
Okay, that makes sense.
Or maybe there's a tiny gradual loss of perfect stability at the screw-bone interface. Not clinical loosening, just enough micromotion to shift a bit more load back onto the healing bone itself.
Huh. So maybe slightly less stiff plates could actually be better sometimes.
It's a possibility. It suggests that allowing a bit more load onto the fracture site earlier, relying less on the plate, might actually encourage the bone to heal more effectively. It's like the bone needs that work stimulus.
Wow, that really flips the stiffer is better idea on its head.
Yeah.
So with all this complexity, why has it been so hard to compare treatments and figure out the best way for mandible fractures?
Well, partly it's the huge variation you see in research outcomes, and like we've been discussing, our understanding of the biomechanics just hasn't been complete. Sometimes there's been maybe a misunderstanding of basic mechanics or treatment choices based on overly simple lab tests that don't really capture the messy reality of a living system. The big challenge is relating the stability the device gives during function to the actual mechanical signals needed for healing. Just being super stiff doesn't automatically mean it's the best environment for bone repair.
Right. Okay, let's get into specific fracture types. What about those posterior body and angle fractures back of the jaw? What happens when we bite in different spots?
Okay, imagine a break back there. If you bite with your front teeth, midline incisor, load the piece of jaw behind the break, especially if the break is in front of the big master muscle attachment.
Yeah.
That piece tends to rotate upwards, so the top edge of the fracture separates, while the bottom edge might separate less or even compress if the bone ends touch. The main tension isn't really in the bone at the top edge, but more in the soft tissues right next to it.
And the idea that biting at the front pulls the front segment down.
Yeah, some old diagrams show that, but it's a bit misleading. That would need active muscle pull downwards or some external force. The bite itself doesn't inherently do that.
Good clarification. What if we bite further back, near the fracture, a molar load?
Right, bite target moves back. Now you tend to see more displacement down at the lower border as chewing muscles fire up, stretching the soft tissues there. If bone ends touch, you might get compression up top.
Okay.
And if the fracture is actually in front of where you're biting, you can also get shear, a sliding motion, which makes the displacement even more complex.
What about biting on the other side? Contralateral load.
That can change things too. If the fracture's right where muscles attach, like the master, biting on the opposite side can sometimes make the muscles and soft tissues on the fractured side actually help stabilize the break, kind of counteracting the forces from the biting side.
Interesting. Okay, let's switch to the front symphysial fractures in the chin. How do they behave differently with the front bite?
Symphysial fractures are different. It's not like a simple cantilever beam fixed at the back. It's more like a curved beam suspended by soft tissues,
Yeah.
with the main muscles pulling from the sides.
A suspended beam.
Yeah, and computer models, finite element analysis, plus primate studies show that in a healthy jaw, you actually get tension at the midline, and it's stronger on the tongue side, the lingual side.
Wow, okay. So what happens with a fracture they're biting at the front?
That incisor bite acts like a pivot. The big master muscles back on the sides pull, causing the two halves of the jaw to rotate outwards around a front-to-back axis.
Okay.
And because of how the muscles pull and the jaws curve, the lower border of the fracture separates more than the upper border. You might get compression up top if the bones touch. But interestingly, you don't really get tension at the lower bone edge unless there's still significant soft tissue holding it together.
And biting right on the fracture line.
Then you get a mixed rotation, sliding, shearing. But the key thing is, there's no good evidence for tension at the upper edge of the symphysis with an incisor bite, which goes against some older ideas.
What if you bite on a molar with that symphysial fracture? Same pattern.
The relative displacements are pretty similar, actually. If there's no bone contact, the sides rotate out, the midline gap widens, resisted by soft tissue. You still get more separation at the lower border, tension in the lower soft tissue, and compression up top.
The soft tissue roll keeps coming up. The source mentioned a circuit theory. What's that?
Yeah, the circuit theory really hammers home how crucial soft tissues are, especially muscles like the masseteric sling wrapping around the jaw angle. It's about how forces get distributed and how the jaw moves.
So muscles generate tension where they attach.
Right, tensile stress at their attachments, which then gets converted to compressive stress where you're biting. As you bite, force travels through the stiffest parts of the bone to the bite point, with maximum compression on the teeth and nearby bone.
But it's not just the bone carrying load.
Absolutely not. When a muscle contracts, it gets stiffer, almost acting like another structural piece. This stiffness lets it transmit force and share the load.
Okay.
Think about a molar bite. Muscles on both sides activate, creating this whole force circuit involving the upper jaw, lower jaw, midface palate, the bite target.
Mm-hmm.
It's all connected.
It's like a network.
Exactly. These facial force circuits have to balance out, involving muscle forces and stress in all the solid bits, including soft tissues. The stiffest part's bone. Active muscle, tough fascia share the load. Think of it like a suspension bridge. The cables, the muscles, and the deck, the bone, both hold the weight.
Great analogy. So how does this soft tissue involvement affect fracture stability?
Well, local muscle contraction can actually increase stability, especially if the break is within the muscle's attachment area and the surrounding tissues, the periosteum, aren't too badly torn up. The contracted, stiffer muscle can carry some load, reducing stress on the bone, and its stiffness helps limit movement. But this benefit is less with front teeth bites, incisor loads, because they cause more bending. And if the fracture is far from the bite point, that longer lever arm makes motion more likely, reducing the soft tissue's stabilizing effect.
This is incredibly complex. Okay, let's link this to stabilization techniques. What's the difference in force distribution between using one plate versus two for, say, a mid-body fracture with an incisor bite?
Right. If you use a single plate on the upper border for that scenario, the plate mainly sees tension. It's being pulled with minimal bending. If you have 4 or more screws, the middle ones near the fracture take most of that load.
And the bone at the fracture.
It doesn't get much direct load transfer initially. The force goes through the plate and screws. As it heals, the new bone starts taking some load. But even fully healed, if the plate's still tight, it keeps carrying load, so the stress pattern isn't quite back to pre-injury state.
What if that single plate is on the lower border instead?
Different story. A lower plate has to resist the upper border pulling apart during that incisor bite. That means more bending load on the plate, not just tension compression.
In the screws?
In a four-screw lower plate system, the load tends to be shared more equally among all screws. But that also means if one screw fails before healing solid, the whole thing is more likely to fail.
And getting it in place.
Yeah, putting a plate on a lower border, whether from inside the mouth or outside, usually means lifting more soft tissue off the bone, which reduces that potential soft tissue stability we talked about.
Okay. What about using two plates then, top and bottom?
With two plates in that mid-body incisor bite situation, the lower plate is now in a compression zone. Its central screws carry most of that compressive load. How much load the plate takes depends on whether the bone ends are touching.
If they're not touching.
Then the plate takes all the compression. Now, if an inner screw in either plate loosens, the load shifts outwards, increasing the risk of 3D instability. Using two plates definitely makes the repair stiffer against bending, no doubt. But that doesn't automatically mean better or faster healing.
Let's talk about angle fractures. You said they're tricky. Why and how does soft tissue factor in there?
Yeah, angle fractures are often a headache. They're common. Severity varies a lot. Getting access surgically can be tough, and there's loads of variation in plating techniques and how much soft tissue gets disturbed. So complication rates are more variable.
And the angle itself, strong or weak?
Well, it's often called a weak spot prone to fracture, but ironically, it takes some of the highest loads during normal molar chewing. The masseter and medial pterygoid muscles form that powerful sling around the angle, pulling mostly vertically, so it's mainly compressive stress during function.
And the muscles help stabilize.
When they activate, they get stiffer, and the surrounding fascia helps too.
So how are they usually fixed, and what about the soft tissue?
Interestingly, a common, often successful way is using just a single small plate, usually along the oblique line or upper border there.
A single small plate.
Yeah. With an incisor bite, that upper plate sees mostly tension, central screws taking the load. With a molar bite on that side, it might tend to distract the lower border, pull it apart. But if the fracture wasn't displaced much initially, the intact soft tissues bridging the gap can often help stabilize it.
And muscle contraction.
Right, when the masseter contracts after plating, it shortens and stiffens, which can actually reduce movement at the fracture. And because placing that upper plate often needs less dissection, less tissue stripping, those undisturbed soft tissues might still contribute to stability during function.
This brings us to that fascinating part of the source about Dr. Ellis's 10-year experience. What did his work show about different plating outcomes?
Ellis's work is really key because it's one surgeon, consistent outcome review over a long time. Historically, you had this push for bigger multiple plate systems like AO, Lura techniques, based on the idea that more rigidity means more predictable healing, like fixing a machine.
Right, the engineering approach.
Exactly. And they got reproducible results. But then you also had surgeons like Michelet and Ciampi successfully using much smaller plates, often put in through the mouth, since the 70s.
So did Ellis find one approach was clearly better, big plates or small plates?
This is the paradox. His review found the best success rates occurred with the smallest intraoral plates and with the largest open approach plates.
What? That doesn't make sense based on the stiffer's better idea.
Exactly. It directly challenges the standard biomechanics of the time. It suggests the bigger, stiffer systems weren't automatically superior across the board.
So if the theory doesn't match the results, what's missing?
It tells us our assumptions are probably incomplete. When you're dealing with living systems, bone, muscle, blood supply, you have to look beyond just the mechanics of the implant.
Okay.
The source says predictable healing needs us to understand how the healthy system works, how much motion the fracture can tolerate, how much load is needed or tolerable for healing, and critically, how much our treatment messes with the soft tissues and blood supply.
We have some quantitative data, like from computer models, right? Finite element analysis.
We do. FEA helps confirm tension compression zones vary with load, but it needs assumptions, boundary conditions. You need lots of runs. But other tests, like Kroon's direct strain measurements and primate studies, support this complex, suspended, curved beam idea where zones can reverse.
But we don't have exact numbers for motion, load, blood supply needed for healing.
It's mostly qualitative. We have a general idea, but not precise figures.
So if maximum stiffness isn't the answer, explaining Ellis's results for both tiny and huge plates, what else is going on?
The source suggests the key differences are likely in how much soft tissue is disrupted by the surgery, how the specific plate screws distribute stress, and how all that affects functional loading of bone, soft tissue, and the device.
It's not just about patients biting less hard after surgery.
Apparently not enough to explain the paradox. And the fact that adding jaw wiring, MMF, to 2-minute plates didn't cut complications further really points to the soft tissue effects being super important.
So the big takeaway is we need to shift focus, not just aim for maximum stiffness.
Exactly. We should evaluate treatments based on how well they promote optimal force transmission across the fracture, considering the whole system, especially the dynamic role of soft tissues.
Even if we can't perfectly measure everything yet.
Precisely. We might not be able to quantify every single contribution from bone, muscle, fascia, blood supply right now, but just ignoring them in our models and planning holds back progress.
This has been incredibly insightful, a real deep dive into jaw fracture biophysics. So, boiling it down, what's the single most important thing for our listeners to take away?
I think the core idea, maybe the surprising one, is that mandible biomechanics isn't just about bone and metal implants. It's way more complex. The soft tissues, muscles, connective tissue, bone coverings, they play a really critical, active role in both stability during function and in the whole healing process. Our treatments have to respect that complexity.
And a final thought for you, our listener, to chew on. In living systems, Forzo is striving for the most rigid, the most unyielding fix, always the best path to a good long-term outcome. Or could a more subtle approach, one that works with the body's own amazing healing mechanisms, actually be more effective in the end? It certainly makes you wonder about other areas, in medicine or life, where maybe the less obvious, more flexible approach wins out when dealing with complex living systems. It's been a fascinating look at the science of healing.